Okay, today we have April day one file the part two one, right? Because yesterday we have finished like more than 100 pages. Like today, other part of the file, okay? Because you all know day one we got like a question like most of the time like a topics, right? Yeah. So yesterday also I have explained we got some topics actually, but don't worry. In the later days, actually after day two, and then you will have proper questions. Okay. So next topic is hyperparathyroidism. So what do you know about hyperparathyroidism, doctors? What is hyperparathyroidism? So hyperparathyroidism mean. So first of all, tell me what is the function of parathyroid hormone? Tell me, doctors. Type in the chat. Today you all feel like very bored, right? What happened? Tell me what is the function of parathyroid hormone. Tell me, doctors. Quickly type in the chat. Doctors. Mm-hmm. Okay. Yeah, there are so many main functions, right? Because as we were discussing in our previous classes, our free theory sessions, right? I have explained about so much thing about this parathyroid hormone related with the hypercalcemia, right? So what is the main functions? It has functions in bone, kidney, and intestine as well, right? So what are the functions in bone? So stimulate bone resorption, right? Indirectly, right? It releases calcium and phosphate from these bones into the blood, right, doctor? So how it indirectly associated? It has the ability to activate this osteoclast, right? So when about what about the kidney? Why, how the function in going in the kidney? It increases the calcium reabsorption, right? Reabsorption in the distal tubules, right? Then decrease phosphate reabsorption in proximal tubules, right, doctor? So those are the things that they are doing in the kidney. Then what about intestine? It also indirectly how it's activate the vitamin D. Then this vitamin D has absorption of calcium and phosphate from the intestine, right? This is the like main function, right? Main function that it affect to regulate the calcium inside body, right, doctor? Yes. So you basically you can remember it's like releasing calcium to the blood, right? Yeah, simply. Very important, okay? Very important. Yes, doctor. And you should know like what are the three mechanisms that are affected in our body because when we discuss about the types, that will help, okay? So right here, parathyroid hormone should be measured in any patient with hypercalcemia. For information about the management, yeah, we have already discussed about hypercalcemia in our other sessions because today is the hyperparathyroidism topic. So we will discuss about the hyperparathyroidism. Okay. So primary hyperparathyroidism, what is it? So we have primary, secondary, and tertiary, right? So what is primary hyperparathyroidism? It's the most commonly caused by a single parathyroid adenome. So you already know, right? Primary mean inside the gland, right? So gland is parathyroid gland, right? So because of that, there is adenoma, right, inside the gland. So primary one. So the definitive therapy is the surgery, right? If there's adenoma, we have to remove it, which gives 95% of cases and has low morbidity, right? So then how we should treat. We have watch and wait approach can be considered instead of surgery in patients who are 50 years or older. Very important, right? If they have given scenario with primary hyperparathyroidism with adenoma, you have to always consider about are we directly going with the surgery or not, right? Here they have given watch and wait option as well for who are more than 50 years or older, right? So here they're older and have a total serum calcium concentration corrected for albumin lower than 2.9, normal kidney functions, no nephrolithiasis or nephrocalcinosis, a bone mineral density T score is higher than minus 2.5. That means there's no osteoporosis, right? And no symptom. These are the cases that we can use watch and wait in older than 50 years old, right? Older than 50 years old. Very important, doctors. You need to remember each point, right? Oh, next one. Next one. So monitor onset of the symptoms and measure total serum calcium concentration and kidney function every 6 to 12 months, right? Because they are a high level of parathormone, that means they affect in the kidney as well, right? And BMD every 2 years because of the bone resorption, right? Using this conservative approach, around 50% of these patients will not require during the surgery in 10 years of follow up, right? Okay, however, this can also result in decreased BMD. So, advise patients who elect not to have surgery to avoid high calcium intakes, right? Limit vitamin D supplementation with cholecalciferol, right? With cholecalciferol. Then maintain high water intake, right? Because you all know if there's a hypercalcemia presence, the initial management is what? Hydration, right? Hydration, like all are together here discussing, right? Okay, so calcium mimetic drugs like cinacalcet can be used for hyperparathyroidism or parathyroid cancer if surgery is not possible or ineffective. Right? So, patient younger than 40 years who present with the hyperparathyroidism should be referred for genetic testing. Patient with primary hyperparathyroidism can also have a moderate hypophosphatemia. Right? This is usually resolved with the management of hyperparathyroidism. So now you have the task. You have to take a pen and paper, then write down primary. Primary, and you all know, right? What is primary due to adenoma? Then treatment options you have. You have the main treatment option, surgery. Then you should write down watch and wait indications, right? Then surgery indications. Then when we can't use this surgery, and we can give these drugs as well, right? Then you have to do the follow up as well. You should know like how you should do the follow up, like every 6 to 12 months follow up, right? For 10 years, and BMD should be measured 2 yearly, right? Because these patients are high risk of osteoporosis, right? Yes. So what about secondary and tertiary hyperparathyroidism? So secondary and tertiary, you already know, that mean outside the gland, right? Outside the gland, that's why we call it secondary. So what are the other causes? So we have um, usually from result of the vitamin D deficiency, parathyroid hormone releases increases secondary response to the low serum 25 hydroxy vitamin D concentration. Secondary elevation of the parathyroid hormone can also patient with the chronic kidney disease. Management include treatment of the underlying cause because it's a secondary one, right? So now tell me what are the other causes for secondary hyperparathyroidism? Other causes for secondary hyperparathyroidism? Just think and tell. Tell me, doctors. Okay. CKD, vitamin D deficiency, what else? If the patient presented with some malabsorptions like inflammatory bowel diseases, right? Celiac disease, like those are the other things. And what else? Yeah, and low calcium intake that can trigger release of the parathyroid hormone, like that. But the main two is CKD and vitamin D deficiency, right? Main two. Then tertiary hyperparathyroidism is uncommon. The mechanism appear to be related to prolonged parathyroid stimulation, like due to secondary hyperparathyroidism, right, leading to an autonomous parathyroid response which produce hypercalcemia. The most common, 1 minute. A most common cause are chronic kidney disease and the kidney transplantation, right? So management require partial removal of parathyroid gland, or you can use that cinacalcet, like that. So there's something you need to know, like perioperative care, because you all know for the primary one, the main treatment is surgery, right? So you should know about this perioperative care for parathyroid hormone, everything from therapeutic guideline. Okay. So here, all patients undergoing parathyroid surgery should avoid excessive calcium intake and maintain good hydration, right? We all know if the patient get hyperparathyroidism and the worst outcome is hypercalcemia, right? For hypercalcemia, the mortality rate is increased due to the dehydration, right? So always the hydration is a main part, right? When we consider these hyperparathyroidism and hypercalcemia, those things. Okay, so vitamin D deficiency can exacerbate primary hyperparathyroidism by causing concurrent secondary hyperparathyroidism. We all know that. If a present correct vitamin D deficiency before surgery with the oral cholecalciferol, right? Overcorrection can increase the risk of kidney stones. So avoid serum 25 hydroxy vitamin D concentration above 100 nanomoles per liter. Okay, so the basic thing you need to know perioperatively. So if you check the vitamin D level, if there's a deficiency present, anyway you should correct it before the surgery, right? But you have to prevent overcorrection as well, right? Because there can be increase the kidney stones as well, right? Doctors. Then we have hungry bone syndrome. Is a state of acute onset severe hypocalcemia that can occur after successful surgery for hyperparathyroidism, usually tertiary. One. So patient at a particular risk of those with both moderate to severe hyperparathyroidism and evidence of parathyroid bone disease like elevated serum alkaline phosphate, concentration of bone origin, etiological features of hyperparathyroidism, osteoporosis, bone densitometry, like that. Okay. Refer patient at risk for hunger bone syndrome for expert evaluation, care before parathyroid surgery. Right? Very important. Okay, I have attached a question. So we'll do this one. 60 years. This is actually related with the hypercalcemia. A 60-year-old woman presented to the clinic for the evaluation of hypercalcemia of 3.22 millimoles per liter. This was found incidentally on a laboratory test panel that was drawn during the hospitalization for cervical spondylosis. Despite fluid administration in the hospital, her serum calcium at discharge was 2.94. The patient is asymptomatic, otherwise, she is in good health and had her recommended age appropriate cancer screening. She denies constipation or bone pain and is now 8 weeks out from her spinal surgery. Today, her serum calcium level is 3.09 and phosphate is 0.74. Her hematocrit and all other standard hematological biochemist tests, including creatinine and everything, normal. Which one of the following is most likely to explain her hypercalcemia? So, what do you think? What do you think, doctors? Tell me, doctors, what do you think? Type your answers in the chat. Okay, now tell me why you are calling it as a primary hyperparathyroidism. What are the key features you can see in here? Why you think it as the hyperparathyroid primary one? Just give it an idea, like that is the knowledge that you need, very useful during the your exam week, right? Right, doctors? Okay, here. So primary hyperparathyroidism and malignancy account for over 90% cases of hypercalcemia. As you I hope all you are remember about March exam and the February exam. They all were very specify about these hypercalcemia. I hope you remember cancer related hypercalcemia. Do you remember about it? Because in February and March, they have very concern about cancer-related hypercalcemia, right? So, in that case, I hope everything is clear. If you have not remember this hypercalcemia lesson, there's a short video, I think around 20 minutes video in the YouTube channel. You can go and have a look, okay? Because I have explained everything like the mechanism, primary, secondary, everything I have explained. Please go and watch that as well. Because this topic hyper calcemia can be repeated again in May exam as well. Okay. So here. In an asymptomatic patient, primary hyperparathyroidism is the commonest cause, right? Patient is asymptomatic, right? In sorry, in patient admitted to the hospital with symptomatic hypercalcemia, malignancy is most common cause, right? So primary hyperparathyroidism result from the autonomous secretion of parathyroid hormone is that no longer regulated by serum calcium level, usually related to the development of parathyroid adenoma. Right. So, like, if you want, I can like quickly explain this hyperparathyroidism very quickly. Do you want to listen from me, or just you can watch the video? Just tell me, because I feel like you have forget it. Tell me, doctors, it's up to you. Quickly. You don't have much time. Yes, okay. Why, Dr. Abab? Now you should be very consider about the this hypercalcemia, right? You have learned like multiple times. Yeah, okay, I'll explain. No worries. Just give me 1 minute, okay? February file. I'll open my note. I mean, doctor, I'm just finding it. Can't remember which file. February day 2. Okay, got it. Just wait a minute, okay. Okay, found it. Okay, this is February file, okay? So you all know like what is the normal calcium regulation. You have not missed too much, doctor. We are still in the first question, okay? Yeah. So so you should know about normal calcium regulation, right? It's from parathyroid hormone, vitamin D, and bone turnover, right? Everything is like basically controlled by the parathyroid hormone, right? As I mentioned, previously, the function of parathyroid hormone, it indirectly affect the vitamin D and bone turnover as well, right? Okay. So here I have explained parathyroid hormone function. Okay, let's discuss about pathophysiology of hypercalcemia. Like pathophysiology, we have three things, right? Because the regulation, if the regulation is increased, then that can cause hypercalcemia, right? So what is happening? Increase the bone resorption, right? Bone resorption increase mean there is a hypercalcemia. So increase intestinal absorption, right? By activated vitamin D, right? Then reduce renal excretion, right? Renal excretion. These are the three main mechanism of the hypercalcemia. So what are the causes? So this is the most commonest cause is primary hyperparathyroidism, right? The most commonest cause due to the parathyroid adenoma, right? Here I have explained it again here, the mechanism, so you can give it a read, okay? Because I have a little bit earlier explained the same thing. Then we have something called malignant related hypercalcemia. Malignant related, very important. This is the second most important one, second most important cause for hypercalcemia. So how this malignancy related hypercalcemia occur? It's not it's not the parathyroid malignancy, okay? Because if there's a parathyroid adenoma, it's usually affect the primary hyperparathyroidism, but this is not directly affect on the hyperparathyroidism, right? Like it's not directly from this parathyroid gland. How it affect? Okay, if there is a malignancy, as example lung or breast, something like that. Okay, so lung or breast. How these malignancy can increase this calcium level? How? We have two main mechanisms, right? We have paratha hormone related peptides, right? Okay, if there's a cancer in lung, this cancer can release some kind of peptide, and these peptide are not paratha hormone, but they can act like paratha hormone. They're acting like paratha hormone and increase those metabolism process and increase the calcium level. Right here, some cancers secrete paratha hormone like peptide, then acts like paratha hormone, then calcium rise, right? But actual parathyroid hormone is suppressed, right? Because this is not the actual one. This is a fake one, right? Fake one. So it's not affecting in the it's nothing to do with the actual parathyroid hormone. This is parathyroid hormone like peptide. Okay. Other mechanism from these malignancies. So what? Bone metastasis. If these tumors are metastasis to bones, then there can be direct osteolysis, right? Because of that calcium release into the blood, because of that this calcium level is increasing, right? This is how the malignancy related hypercalcemia occurred, right? But the most commonest one is primary hyperparathyroidism caused by these parathyroid adenoma. Okay, then because of vitamin D excess also can cause hypercalcemia. How? Vitamin D increase the gut absorption, right? We all know gut absorption increased by vitamin D, activated vitamin D. So because of that, there can be increased level. So excess supplementations, this can be the cause, right? So reduction of renal excretion, right? So thiazide increased calcium reabsorption, dehydration was the hypercalcemia, like that. Okay, but you should be very concerned about primary hyperparathyroidism and the malignancy related hypercalcemia. Very important. Those are the two main causes for hypercalcemia. Two most commonest. Okay. Then next you should know about this hypercalcemia is parathormone dependent or parathormone independent, right? Parathormone dependent means if there is some primary hyperparathyroidism, something related with this thyroid gland, there is example primary hyperparathyroidism. It's a parathormone dependent, right? There's excessive hormone, because of that only the level of increased calcium present, right? But we have parathormone independent. As example, best example is those malignancies, right? Because there are no direct effect with the parathyroid hormone, but they can secrete something like that, parathormone, like peptide, like that. Okay. Then parathormone independent mean vitamin D and excess, thyrotoxicosis, adrenal insufficiency, milk alkali syndrome, neoplastic related disease like parathyroid hormone related protein or peptide, sarcoidosis, thiazide diet, like all other things are included in these parathormone independent causes, right? Yes. So the clinical features we remember it as stones, bones, groans, psychiatric overtones, right? This is how we should remember it, right? It's very easy. So stones, renal, colic, hypocalcemic stones, bones, increased osteolysis and fractures, psychic moans mean depression, confusion, hallucinations, and coma because of the increased level of calcium, right? Abdominal groans like anorexia, nausea, vomiting, these things. And muscle weakness, malaise, hyperreflexia, those are the other things that you can see, right? Very important. Then stepwise investigation. This is the best, most important part they have asked in the previous month's records. Okay. So stepwise, first you have to confirm the hypercalcemia, right? If there's a level of calcium is increased or not, right? Then you have to check the parathormone level because you all know the most common cause is the parathormone. Hyperparathyroidism, primary one. So you have to check the parathormone level. Why? You have to get an idea. Is it parathormone dependent or parathormone independent, right? Then it will be easy to find out the cause, right? So if parathormone high or normal, so primary hyperparathyroidism. So if parathormone low, you can think about malignancy, vitamin D excess, granulomatous disease like that. Okay, then you have to find out what is the exact cause. At vitamin D level or like myeloma screen, you have to find out because sarcoidosis is also having hyper calcemia. You have to find out later, right? But first you have to confirm it, then you have to identify it's a parathormone dependent or independent, then only you can do the further investigation, right? So acute severe hypercalcemia, the initially what we should do is rehydration. So sodium chloride 0.9%, 4 to 6 liters by intravenous infusion over 24 hours, right? Very important. So what are the additional treatment? Okay, in adult with severe hypercalcemia of any cause that has not responded to rehydration, consider using intravenous bisphosphonate. Who who did not respond to the initial rehydration, only we are thinking about this intravenous bisphosphonate. Very important. So you can give solendronic acid or primidronate, right? Then uh, yeah, if it is vitamin D deficiency, you have to give vitamin D like that. Okay, you have to treat the cause. Then most important one is this one. This is the one they have asked in the exams. Hypercalcemia associated with cancer, right? Cancer. How you should treat doctors in here. Initial symptomatic hypercalcemia associated with cancer is anyway. Initially, you have to give the rehydration, and additionally, bisphosphonate may be required, right? Why these patients are related with the cancers, right? Related with the malignancy. So you need additional treatment other than intravenous rehydration. So what are the treatment you can, what are the bisphosphonate you can use? And before giving bisphosphonate, you have to consider these things. After initial intravenous rehydration, consider bisphosphonate for patient with hypercalcemia associated with cancer who have serum total calcium concentration corrected for albumin is of 3 or higher. Symptoms and a serum total calcium concentration corrected for albumin between 2.6 and 3. If calcium level more than 3 or more, or symptom presented and calcium level between 2.6 to 3. These are very important. Then you have to add these bisphosphonates. So what you can use pamidronate intravenously or solendronic acid intravenously. Very important, doctors. Very important. Yes, very important. So remember these two criteria, okay? These two criteria because in the exam they can ask from this, right? Yeah. I hope you remember now, Right, Dr. Abba? Right, Dr. Sandali? I hope you remember, right, Dr. Grace? Yes, these are like multiple times I have explained this topic. Even I remember each point. Okay, next question. Male unilateral gynecomastia treatment. Okay. So now tell me about unilateral gynecomastia. What do you know? Like when you see unilateral gynecomastia, what is in your mind? Like, okay, we have two things, bilateral and unilateral, right? Okay. Now tell me causes for bilateral gynecomastia. Tell me, doctors, bilateral gynecomastia causes. Tell me, doctors. Just give me example because you all are exam oriented doctors, right? Okay, it can be physiological. Okay, very good. Okay, side effects of medications. Give me example. Spironolactone, right? Mainly it's spironolactones and other anti-androgenous. Like these, what are those steroids, right? Like finasteride, those things. Like mainly spironolactone. Okay, aging as well. Okay, and hormonal, right? Endocrinal due to hypogonadism, right? Especially in the children like Klinefelter syndrome, right? Then what else? In chronic kidney disease as well, right? Chronic kidney disease, very important, right? Very important, doctors. So, and there's a idiopathic as well. Okay, for bilateral. What about unilateral gynecomastia? Unilateral gynecomastia. Unilateral gynecomastia. What is the main thing that comes in your mind when I ask about unilateral gynecomastia? What it can be? It can be a cancer, right? It can be a cancer mainly. Okay, here, doctors. Mm-hmm. Here, how common is one-sided gynecomastia? So, gynecomastia is surprisingly prevalent across the male lifespan. It occurs in over half of male newborn due to the maternal estrogen level, affect up to 60 to 70%. Or puberty boys as a temporary condition and increase again when over 50 due to age-related change in hormone level. Okay. Then, with this border population, the meaningful subset present with the unilateral or clearly asymmetric gynecomastia. So now tell me, yeah, here. Hey, true unilateral gynecomastia, however, involve palpable glandular tissues concentrated on one side, creating a noticeable difference, right? Because if it is a one side gynecomastia, there we have to think about the tumor, right? We have to think about cancer. So, what are the common benign symptoms? The typical presentation: a rubbery or firm glandular tissues, this like directly beneath the areola on the side, visible breast mound on puffy nipple creating asymmetry, mild tenderness or soreness, especially during the early growth, a stretching or itching of the overlying skin as the tissue expands, sensitive nipples on the affected side. These are the like benign symptoms that you can see. Okay, then what are the warning signs of male breast cancer requiring prompt evaluation? So, a very hard, irregular, or fixed mass not centered under the nipple, a nipple retraction, scaling, crusting, bloody nipple discharge, rapid growth over just few weeks, enlarged lymph nodes or firmness in the armpit area, right? History of breast cancer in the family, prior chest radiation, or non-sick factors for breast cancer. So these are the warning sign, right? Warning sign, but these can be the benign symptoms, right? Benign symptoms, but from these also we can identify the early signs of the cancer, right? Early signs of the cancer. So yeah, how to diagnose this one? How do we evaluate the one-sided gynecomastia? So unilateral gynecomastia, we usually consider it as the cancer until proven otherwise, right? So in that case also we have to use this chart, right? I hope you remember this chart is very familiar. Like each month they are asking something from this chart, right? Either from the cyst, mass, like that. Here, what we should do. Okay, here, clinically benign mass or nipple change, what we should do, or suspicious of malignant breast or nipple change. So initially we have to do the imaging, right? Mammography or ultrasound, right? Mammography or ultrasound we have to do as the initial imaging, right? Like after the imaging only we decide how we should treat. If it is a simple or if it is a solid lesion. Okay, here if it is a solid lesion, what you should do, you have to do the, usually we are doing the core biopsy, right? Core biopsy, and then we are sending sample for pathology to identify whether it's a cancer or not. Like that, right, doctors? So you have to always think about the tumor, right? Okay, so how we diagnose, how we differentiate bilateral gynecomastia from unilateral gynecomastia? So here, most likely cause systemic or hormonal, unilateral one, local or early changes. Physiological here, rubbery, elderly, neonatal, but unilateral is rare, right? Physiological one. So drugs, here spironolactone, anti-androgen steroids, antipsychotics, cimetidine, those other drugs they can cause, right? So endocrine, here hypogonadism, hyperthyroidism, right? But in this case, like unilateral one, they are less common, right? Less common. So systemic diseases, it can be due to liver disease, especially alcohol-related liver disease, right? There can be, we can see the bilateral gynecomastia or CKD, but in unilateral case, rare, right? Tumors. Oh, in bilateral gynecomastia also there can be testicular tumor, right? Often, but bilateral. So unilateral one, possible early, right? Possibly early tumors, we can say. So malignancy, this is the most important cause for unilateral gynecomastia. Very important, and asymmetry, we can see heart irregular, synthetic mass, nipple changes, lymph nodes. These are the things you can see, right? You can see. And the management is like it's according to the type of cancer and everything, right? So we got a better question in the future file. In that case, I'm explaining like everything, like how to do the treatment, how to stage the cancer, how to do the staging of the breast cancer first. Then you have to identify what are the local treatment, like what are the type of surgery, because we have different types of surgery, right? We have local excision of the tumor, right? We have we have radical mastectomy, right? Those treatment with or without other like chemotherapy, especially radiotherapy, like that. That's a different thing, okay? But in the future file in April, we got a better question later, and I will explain from that question. Okay, for just now, you have to just identify how unilateral gynecomastia and bilateral are separated, and what is the most common causes, and what is the diagnostic algorithm as well, right? Okay, I hope everything is clear. Don't worry. These questions are repeated in next days. Then you will get the like proper scenario, and we will discuss like properly how to approach in that case. Okay, in that case. So don't worry. So next one, postmenopausal bleeding, thickened endometrium on scan investigation asked. So what do you think? What we should do? Postmenopausal bleeding, thickened endometrium on scan investigation asked. What we should do? Tell me, doctors. Very, very easy question. Every month they are asking from these things. And I'm explaining. Yes, very good, doctor. Very good, Dr. Grace. What about other doctors? Okay, we'll do this question first. This question, I think I'm explaining this question so many times, right? Here, 65-year-old woman present to the GP clinic with 3 episodes of vaginal spotting during the last month. She reports some mild bloating, but otherwise well. She went through menopause 7 years ago and is not any hormonal replacement therapy. Is an abnormal and speculum examination is unremarkable. Cervical core test and chlamydia and gonorrhea. High vaginal swabs are performed during the examination and return to normal. So, which one of the following is most appropriate definitive diagnostic test? CT pelvis, endometrial biopsy, endometrial dilation and curettage, low vaginal swab, transvaginal ultrasound. What do you think? Yeah. Listen this carefully. This question is repeated in like every month. Every month, okay? The presentation consistent with postmenopausal vaginal bleeding. Any postmenopausal vaginal bleeding considered to be endometrial cancer until proven otherwise. The most important thing you should remember in postmenopausal woman, right? Postmenopausal woman, the postmenopausal, if there is any postmenopausal bleeding, we are considered as the endometrial cancer until proven otherwise. Very important, okay? So, endometrial biopsy is the definitive diagnostic test for postmenopausal bleeding in line with the current guideline here. So, any postmenopausal bleeding should be considered to be endometrial cancer until proven otherwise. Endometrial biopsy is the first line definitive diagnostic test for menopausal bleeding, right? Very important. Okay, here. And you noticed here they have already done the core test, right? They have already done the core test, and here they have ruled out the STI as well. Okay, this is the guideline. Investigation people with abnormal vaginal bleeding. If it is a postmenopausal bleeding, so we are initially doing the core test, right? Initially doing the core test and refer for gynecological assessment regardless of test result, right? Because we need to always rule out these malignancy. We have to always rule out these endometrial cancers first. That's why here also they are mentioning refer for gynecological assessment. That means they want to take the samples for the to rule out endometrial cancer. But remember, like core test also we have to done if the patient presented with postmenopausal bleeding. Very important, okay? Core test and uh, cortex and the definitive diagnosis is what endometrial biopsy. Very important, okay? Remember this one. And here, this is the March recall. 52-year-old woman present with the postmenopausal bleeding. What is first investigation? And here they have given pap smear, abdominal cervix, then CT abdomen, CA125 reassure. And here we can get the core test. We all know, right? Currently, we are not doing the pap smear, right, in Australia. So pap smear is anyway out, CT abdomen out, CA125 out, reassurance is out. So the only thing we can do is endometrial biopsy. This is the definitive diagnosis, right? I think in the STEM they already have done the core test and core test. Then they are asking like that in our question, okay? So always think like according to what they are asking, you have to treat it. Anyway, you have to think endometrial cancer until proven otherwise. That's the very important one. Okay. So most of the cases they are asking from this biopsy part. Okay. So because of that, keep these points in your mind. Transvaginal ultrasound doctor, like I can't tell like exact like algorithm because there's no algorithm for this transvaginal ultrasound. If we suspect like other pathologies like something like anyway after these biopsy and everything, then only we can consider other investigation. Because like initially we have to done this according to the result and everything. You can decide, do we need further investigation, or you do we need to remove the tumor, like that. Okay, there's no algorithm for ultrasound. Yeah, doctor, if the core test is not haven't done, so initially we can do the core test. But if they have asked the definitive one always go with what? Biopsy. Biopsy, very important. Even in that question also, they have mentioned regardless of the core test, we have to refer for the gynecologist, right? Refer for the gynecologist. Anyway, you should not wait for the core test result. Always biopsy comes first to rule out the endometrial cancer. Yeah, yeah, Dr. Cortes. Yes. Yeah, yeah, doctor. Yes, very important. Very important. Okay, 1 minute. Yeah, you have to answer. You have to answer accordingly what they ask. Most of the time, they have given like this kind of question. They already done a core test, right? Because then you have to go with the definitive one. Anyway, the biopsy is the best thing you need to do, right? Because regardless of the core test, anyway, we have to do the biopsy, okay? But initially, if the patient comes with this postcoital test, sorry, this postmenopausal bleeding, then you have to, like usually as Dr. Abab saying, the GP should do the core test, then refer for the endometrial biopsy. That's the normal algorithm. You have to answer according to the question, what they are asking actually, like that. Here, even in this question, they have asked what is the first investigation. We didn't get the options as the core test, right? We didn't get any option as core test. So anyway, then we can assume they have already done the core test, right? Like that. But doctor, yeah, yeah, doctor, we are doing this HPV and this LBO for the screening. Yeah, yeah, that's a different thing, right? Don't confuse these things. So we are doing screening for who? Okay, tell me, we are doing screening for whom? Who needs screening? Who needs screening? Yes, asymptomatic. If the people doesn't have any symptoms, we are doing screening. Why? To identify if there are any abnormalities. But this is the different case. This is a postcoital, sorry, this is a postmenopausal bleeding present, right? Like every day I am telling, we are doing screening for who? Asymptomatic patients. Say screening, right? Not a treatment. But now here what we are doing? There is a symptom present, right? Here, this is another chart. Symptom present with abnormal vaginal bleeding. So we are not doing screening for people who are having symptoms, right? Because screening for asymptomatic people. First, understand the difference, okay? Who are the people that we are doing screening and who are the people we need to treat, right? I hope you understand. Very important, okay? Okay, this question, very weird question. Okay, red swelling, scrotum extending into penis, diagnosis. So don't worry. In the later days, we got the question with the idiopathic scrotal swelling. That is the scenario. Okay, idiopathic scrotal swelling. Don't worry, we got the question later day because day one is like just a very very small amount of questions, right? Like that. But day two we got a proper question like that. Okay, so we got a question in day one. Red swelling scrotum extending into penis. They're asking diagnosis. So, red swelling scrotum. Okay, now tell me, red swelling scrotum, what are how we should categorize this scrotal swelling? We have something called painful scrotal swelling and painless scrotal swelling. I'm just asking generally, okay, because we can discuss this topic once get the proper question. Yes, painful and painless. Now give me example for painless scrotal swelling. Painless scrotal swelling. Example for painless scrotal swelling. What we have? What we have, doctors? Okay, hydrocele, varicocele, cancer, what else? Idiopathic sclerosis, spermatocyst, very good. Epididymosis, yeah, those are the usually painless one, right? Okay, yes, all types of seals. Very good, doctor. Yeah. Okay, now tell me, what are the painful scrotal swelling? Painful one. You need to remember four main things, usually three things. Actually, it's four things. Mm-hmm. Yes, epididymitis, right? Epididymochitis. All types of IT. Okay, okay, you can remember like that. Then torsion we have. Then what are the other two main things that I was always telling during our recall sessions because they mention in the e-medicine. What are the other two things? Painful scrotal swelling. Okay, keep the hernia aside. What else? Hematoma. I hope you remember. Hematoma, right? Most related with the spot injuries. Then what we have the rupture, right? Yeah, you need some hint, right, Dr. Abab? Then you remember. Okay, anyway, you remember it, right? Yeah. Testicular rupture, right? Very important. If you have familiar with emergency questions, you should already have done these questions, right? Very important. Like not torsion, epididymitis, not those things only cause the painful scrotal swelling. We have other two things. Hematoma cases also they have given. The testicular rupture also they have given. Very important. If you have not done it, please go and do the scrotal swelling because they are very important, right? Very important. Then we don't know either it's a painful or not. Just red swelling of scrotum extending into penis. So what does that mean? Extending into penis. So what does that mean? Tell me, doctors. What is it? Just give it an idea. Mhm. It's usually this swelling is spreading, right? This swelling is spread into like surrounding other genital tissues, right? Right here they have mentioned towards the penis, right? It's spreading, right? Doctor, spreading, right? Okay. So what are the possible causes? There can be cellulitis, right? There can be cellulitis, right? There can be these idiopathic scrotal swelling, right? Right, doctors, or there can be trauma, or there can be allergic angioedema, right? And hernia also can be, we can think, and we have something other one is called fournier gangrene as well. It's a very emergency case, right? Emergency case. Yeah, like so many things, right? So many things, but not everything is extended into the penis, right? So, like you have to remember cellulitis is idiopathic scrotal swelling, then these hernias, right? Hernias, then what else? These fournier gangrene, those are the possible causes. But we actually doesn't have a proper idea, right? Proper a STEM. So because of that, I have attached some questions in day one file. Then to get an idea, okay? Because let's discuss about little bit dysphonia gangrene. It can also ask, okay? Here, can you see it's extend to the penis as well? Here, there's a picture also given. So you need to answer. You need to know this one as well because this is a medical emergency. Okay, 53-year-old man present to the emergency department with 2-day history of increased scrotal pain, nausea, lightheadedness, and shakes. His medical history include type 2 diabetes, hypertension, hypercholesterolemia. On examination, he's in obvious discomfort. His blood pressure 90/70, pulse 110 and temperature 38.3, BMI 31. There is a widespread discoloration with sharp demarcation on over the scrotum here. You can see that demarcation. The scrotum is warm and markedly edematous, and even the lightest palpation result in significant pain. Further examination is not practical because of his pain. So they're asking which one of the following most likely to diagnose. So you all know, like because I was telling previously, it's a fournier gangrene, right? Fournier gangrene. So here, fournier gangrene is necrotizing fasciitis is a polymicrobial synergistic infection originating subcutaneous tissue, and the perineum and the male genital is a common site of origin. Very important. It's a necrotizing fasciitis, right? You can see the necrotic tissues here, right, doctors? Yeah, here. Then the pathophysiology process usually involves the spread along the subcutaneous facial layers, and the immunocompromised or diabetic patients are most prone to this problem. Necrotizing fasciitis is a life-threatening condition that require prompt recognition and interventions after fluid resuscitation. Broad spectrum anti-intravenous antibiotic must be given and surgical debridement done as soon as possible to remove all necrotic tissues. So you have learned what is the treatment algorithm, right? Anyway, this is the emergency case. You have to stabilize the patient, like by giving the fluid resuscitation. Then you have to start immediately IV antibiotic, and at the same time you have to do the surgical debridement, right? Surgical debridement, very important because there is a necrotic tissues, right? Necrotic tissues. So how these scrotal cellulitis present? How is a reasonable differential diagnosis for patient in the stem above. However, given in the evidence of systemic involved and picture evidence necrotic, no, they have not explained it here. Okay, the scrotal cellulitis, erythema, warm, tenderness, diffuse swelling, you can see. Okay, yeah, here I have explained very simply. Okay, okay, now there's another question. 15-year-old to differentiate different types, okay? 15-year-old boy presented to the emergency department with 5-hour history of left scrotal pain in the swelling. He reports some nausea with the pain and vomiting. He was playing football and was hit directly in the groin by a ball. 6 hours ago, he describes that pain initially went away but came back severely after the game. He has no significant medical history and no regular medications. On further questioning, he reports being sexually active with one partner and using condom inconsistently. He denies dysuria but has had white discharge from the penis. His parents suggest he has a low pain tolerance. On examination, he appears distressed with normal vitals. Left hemiscrotum is swollen and tender with some slightly bruising seen over the upper pole of testis. The cremasteric reflex is absent on the left side. There is white discharge from the penis with surrounding redness. Which one of the following is most important next step in management? So tell me, doctors, what do you think? Tell me, doctors. Mhm. Okay. Why? Why B, doctor? Why? Why B? So now tell me what are the features of torsion? Features of torsion. Tell me, because you need to differentiate these things, right? Okay. Okay, severe pain, very good. It's a sudden onset severe pain, right? Swollen testes. Okay. And this is associated with nausea and vomiting in the most cases, right? Right? Then what is what we can see? What about the testis, like the position, the location of the testis? How it present? How is the position present of the testis? High riding testis, you can see. Very good. High riding testis, right? Very important, right, doctors? Yes. And pain is a very severe one. Okay. No chemistry reflex. Yes. Very good, doctors. Yeah. Here. So you have most appropriate next is the surgical exploration. The patient in sexual history could be potential risk of STI, and history of recent trauma could suggest the acute bruising. However, it's not possible to clearly exclude testicular torsion with the history of severe pain, absent chemostatic reflex, swollen testes, and presence of nausea. The surgical exploration should be completed. Urgent surgical treatment, especially within 6 hours of symptoms. Onset is essential to maximize the chance of testicular salvage, right? Right, doctors? Yeah. Okay, so what about idiopathic scrotal swelling? So it usually refers to acute idiopathic scrotal edema or AISC, right? This is a benign self-limiting condition seen male in children but can occur in adult as well. The typical features: sudden, painless, or mildly painful scrotal swelling, redness of the scrotal skin, edema may extend to the perineum, groin, or penis. Child otherwise look well, testes are normal and non-tender, no urinary symptoms. It can mimic torsion or infection. Okay. Yeah, the diagnosis mainly clinical, but scrotal ultrasound with Doppler if torsion cannot be excluded initially, right? So ultrasound finds scrotal wall thickening like edema, normal testis blood flow, sometimes called fountain sign. That means what? Increases scrotal wall vascularity, right? Yeah. So the management, reassurance, and state analgesia, because this is the idiopathic scrotal swelling, right? Rest and scrotal support, right? Usually resolve within the 24 hours to 72 hours. And doctors here also I have attached like epididymocarditis. Okay. Tell me how epididymocarditis present. Epididymocarditis, very important. It also having a pain. Is it a gradual or sudden onset? The pain. Okay, pain gradual or sudden onset. It's a gradual, right? Okay, so pain severity is this very severe or like moderate pain? Severe or moderate pain. It's a moderate pain, right? Then what about other systemic features like fever, right? And other UTI symptoms can be present, right, doctors? Then we can see swollen red tender, right, doctor? Tender, this scrotum, right? Yeah, like that. Okay, and cremasteric reflex is preserved, right? Yeah, yeah, like that. Okay, so don't worry, we'll get good questions in later days. For now, just keep these things in your mind, okay? In your mind. So we'll move to the next question. Okay, this is the question. This is the one the recaller has shared. Okay, this is the chart. So there was a graph like this. Vaccine against virus A was given to the community, asked why incident of virus B increased after vaccine. This question came on each single day, even day 5. Do you remember the Dr. Kumari and other doctors were not very active in the sessions. Do you remember Dr. Kumari? She did the exam week recalls with me, and yeah, she got a lot of recalls. Like this also given the she was given the like same recall after the session. Okay. So what do you think? What is this doctors? Like just do you have any idea? Do you have any idea, doctors? What is this? What do you think? Okay, here. Okay. Here, this is the incidence. We have A, A virus and B virus. Okay, previously A and B virus both are present. Now they have introduced some vaccine, right? They have vaccine again the A virus. Then this happened. Okay, let's discuss. Yeah, before vaccine, what is happening? So before vaccine, okay, there are three scenarios. Not actually three, like two scenarios. So before vaccine, we have what? Virus A and B both present, and they complete in the same population. They compete in the same population, right? Because there's like they are using the like same environment, right? Same environment, and both are present. Okay, here. Okay, I'm just making okay. A B A and B virus are present at the moment. Then after vaccination, there's a vaccination against A. Okay. After vaccination, okay, they are in the environment like this. They both are compete with each others, and but they both are having like same scenario, right? Because like nothing affect, there's no vaccination like that. Oh, here. Then after vaccination for virus A. So virus A, the vaccination has introduced, and because of that, this virus is reduced, right? Because there is something against this vaccination, right? Something against this vaccination. So something against this virus, and the virus is decreased from that population, right? Because of the vaccination, right? Okay. So the competition is removed, right? Previously, both A and B are compete in the same environment. Now, we are giving something vaccine for virus A, and the virus A is reduced, right? Decreased, right? Then there's a no competition, right? B is having everything because now A is decreasing, right? B is having everything for their self, right? So then what happened? The result, virus B get more space and more resources, right? Okay, he's getting more resources because of the vaccination. Okay, he's getting more resources. Then incidence of virus B increases. Why? The new cases of virus B increases. Why? The virus B is getting more resources and he's getting the very stronger, right? Because there's no competition, and now he's getting very strong, right, doctor? The incidence of virus B is due to the strain replacement. We call this strain replacement after reduction of virus A following a vaccination, right? Virus A decreased because a competition has decreased. Then virus B has more sources and he is increasing their incident, right? He is infecting people. There's no resistant cases like vaccine or anything for virus B is rapidly increasing. I hope you understand this. It's a very simple theory, right? Very simple theory. Did you understand everything? Is everything understandable about the chart? Okay. Now, okay, in day one, we just got the chart and those things. In the like later days, they are directly asking what is happening here. So, strain replacement. This is the thing they are happening in here. Strain replacement. Okay. So in later days, day 4, day 3, day 5, they have directly asking, given this scenario and asking what is the phenomena. Then it's a strain replacement, right? Very important. Okay. No, doctor, no vaccine for virus B. Just only introduce a vaccine for virus A. Then because of that, this happened, right? Because the equilibrium in the environment from A and B, the competition and everything has disrupted, right? So A is decreasing, B has more resources, and he is getting it stronger and infect the people. Very simple theory. Very simple. Okay, keep these things in your mind because in every day this question is repeated. Later they have asked about this phenomena strain replacement, right? Okay. So the hemothorax management. Now tell me hemothorax management stepwise. Okay, stepwise. You don't have time to, especially who were with me with my recall classes. This topic is every month repeating. Very important. Very important. Now tell me stepwise. Okay. What about, okay, what is, mm-hmm. Okay, I'm giving the scenarios like this. Okay. There's a patient after motor vehicle accident, then patient is stable now, and when we percuss and we find out there's a dull sound and decreased breath sound. So dull sound we identify. Then what we should do initially. Okay, we have identified there is a hemothorax. Initially what we can do, Okay, chest tube drainage. Okay, test tube. Sorry, not test tube, chest tube drainage. Okay, very good. Okay, then after the initial drainage, 1 minute, doctor. Okay. So after this initial drainage, that we find out there is a 1.5 liter blood is accumulated through this drainage. Then what we should do? What we should do, doctors? Next, what we should do? Yes, very good. Very good, doctor. Very good, right? Yes. Okay, I'll explain. Um, we have to go with thoracotomy, right? Thoracotomy. And tell me, chest tube insertion, the other name of chest tube insertion, the other name of chest tube insertion. Yes, we call it tube thoracostomy. Thoracostomy, right? Thoracostomy. Okay, so don't confuse this thoracotomy with thoracostomy, right? Very important. Okay, I'll explain. Okay, just I want to make sure that you remember the points. That's all. Okay, here. Okay, if there's a hemothorax patient present. Okay, first of all, tell me what are the clinical features of hemothorax patient? Tell me. Most of the time they are given after motor vehicle accident, right? Okay, difficulty in breathing, sudden chest pain, right? Pleuritic pain, cough, like then we can see tachycardia, tachypnea, pale, sweating. Okay. And respiratory examination, what we can see decreased breath sound in affected area, right? So there is a dull sound, right? Dull sound on percussion, right? Reduced chest expansion. Those are the things, right? Okay. Then okay, we'll go one by one. So, what are the investigations? What are the investigation, doctors? What are the investigations for here? What is the investigations? Yeah, we can do the chest X-ray, right? So, what is the sign that we can see in the chest X-ray? What is the sign we can see in chest X-ray in hemothorax patient? Very good. Meniscus sign. Okay, here. Here, X-ray shows the left-sided hemothorax. Here, we call it meniscus sign. Here, can you see blood is accumulated here? And this is the sign, hemothorax, yellow arrowhead. Here, this is we call is meniscus sign, right? Meniscus sign, very important here. It's a blood accumulated here and here. So where is the? This is the CT image. So tell me where is the hemothorax? Okay, I'm marking A, B, C. Where is the hemothorax? Yes, A. So what is B? What is B, doctors? What is B? What is B? Yeah, this is a small pneumothorax as well, right? So where is the lung? Where is the lung? Where is the lung? Here, can you see the lung is here, right? Lung is here. It's due to this pressure, due to this force from the hemothorax and pneumothorax, it's a collapse, right? Lung is collapsed, right? Here's the normal one. Here's a collapsed lung, right? Yes, very important because sometimes they can give the scenarios, right? Okay, now we'll do some questions. Then we will go back to theory. A 23-year-old woman, sorry, old man present to the emergency. This is the kind of scenario that they can give. Department after sustaining a stab wound to the chest during the altercation. He has a significant medical history No significant medical history and no regular medications. On examination, he appears fully alert and oriented, able to recall all events surrounding the injury. His breathing is labored with the respiratory rate 28, pulse 120, BP 90 by 60, then temperature 37.3. SpO2 96, examination of chest revealed 3 centimeter laceration in the left mid axillary in the fifth intercostal space with the underlying muscle visible. There's a reduced air entry in the dullness to percus and the left side of the chest. He has no other injuries. An IV catheter is inserted and fluid resuscitation commenced. Which one of the following is most appropriate next step? What do you think? Mm-hmm. Yes. Here, what we should do. Okay. Here, the patient presents with signs of hemodynamical instability suggestive of hypovolemia due to the blood loss from the chest laceration. His labored breathing, reduced air entry, and dullness to percussion on the left chest are consistent with lung collapse, compression, and fluid collection, indication of open pneumothorax and hemothorax. The priority is to replace the loss of blood and drain the chest, facilitate the lung re-expansion. Intravenous isotonic saline should be rapid infused while prompt intercostal drain is inserted to allow the egression accumulation blood and air from the pleural space, right? I hope you understand. If the patient is hemodynamically unstable and patient is deteriorating, we are not waiting for any investigation. We are just suspecting it, and we have to do the initial interventions by, because we need to re-expand we have to we need to re-expand the lung, right? And you need to resuscitate the patient, because if they're hemothorax present, there can be a massive bleeding, right? Patient can be hemodynamically unstable, right? So like that. Okay, this is okay. You can give it a read other things later. Okay, here. Next one. 25-year-old man present to the emergency department. Okay, you can think the same scenario, 2 centimeter laceration, and this is the a chest X-ray show the large left-sided pleural effusion, two large bore intravenous lines inserted, and the blood is sent for full blood count, coagulation profile and group and cross match. So normal saline is commenced on O negative blood is requested. A large bore chest drain is inserted. They have already inserted the large bore chest drain. Then the drainage. The second scenario that I have explained, the drainage is 1.5 liter of blood immediately. Then they are asking which one of the following appropriate next step in management. Patient already done the initial intervention with chest tube, and here after chest tube insertion they have done the chest x-ray as well, and they have found out the large sided pleural effusion. Okay, so what we can do in here, in this case, what we can do, doctors? And what are the doctors? Very important. Yes, here. Urgent thoracic surgical review. They can give this thoracotomy as this surgical review. Okay, as they can mention like this as well. Okay, here. The patient present with massive hemothorax following penetrating chest trauma. The immediate drain is 1.5 liter of blood, indicate the significant intrathoracic bleeding given in the patient's unstable vital signs and the large volume blood loss, very likely that urgent surgical intervention is would be required. Okay, here. This is the theory that you should remember. Urgent thoracic surgical review essential as the patient may require emergency thoracotomy. Indications for thoracotomy is hemothorax include initial drainage, more than 1.5 liter of blood, or ongoing blood loss more than 200 milliliters per hour for 2 to 4 hours, or hemodynamically instability despite resuscitation. We'll go back to our theory. Sorry, here 2 to 4. Okay, here. So the hemothorax management. First thing first, we have to follow the emergency protocol, ATLS, right? So first stabilize the patient, airway, breathing, circulation. If the patient is having less oxygen saturation, you have to give the oxygen as a circulation. You have to insert two large cannulas, then fluid resuscitation if needed, then blood transfusion if needed, you have to done it. Then immediate treatment is chest tube insertion, or we call it tube thoracostomy, right? This is the first definitive treatment, very important. Drain blood from the pleural cavity, allow lung re-expansion and measure the blood loss, right? So the site is fifth intercostal space, mid-axillary line. Then you have to monitor the drainage, right? After inserting the chest tube, measure the blood output. If bleeding is severe, surgery needed. So thoracotomy indications. So what are them? Initial drainage is more than 1.5 liter. Ongoing bleeding more than 200 milliliters per hour for 2 to 4 hours. Persistent hemodynamical instability. Suspected major vessel injury. These are the main indications that we are going with thoracotomy. Very important, right? So additional management, oxygen, analgesia, hemoglobin monitoring, repeat imaging, we can do. So very simply, the algorithm is chest trauma and suspected hemothorax, stabilize ABC, then insert chest tube, then check drainage. According to chest drainage, we can, sorry, just 2 to 4. We can just think about the emergency thoracotomy, right? It's according to the these indications. I hope everything is clear, right? I hope everything is very clear for you, right? Is there any doubt? Is everything clear? Because most of the doctors who are doing recalls with me, they are very clear about these things. What about other doctors? Like who are the newcomers? Did you understand everything? New doctors, yes, right? Everything is very clear, right? This is the algorithm. Like if you know this algorithm, you don't have to worry, right? Everything is in this one page. Everything is in here. These are the everything you need to know from this hemothorax. Very important, right? Very important. And you all, everyone know the AMC is the what? AMC's AMC's guideline based exam, right? They always prefer algorithm, the stepwise order, right? Here. So because of that, you need to be more careful. Here also another question I have attached, so you can give it a read. Okay, next one. Increased ACR, albumin creatinine ratio, change perindopril to indapamide or start sitagliptin or empagliflozin. So increase albumin creatinine ratio. Albumin creatinine ratio. So what does mean? If ACR is increased, what does mean, doctors? It's a very important because in March also they have given this kind of question. This can be the same recall because like previous month recalls can be repeated because we don't know the scenario. We don't know the scenario, doctor. But they are asking increase ACR, change phenylpropyl to indapamino, star sitagliptin, empagliflozin. Right? Do you remember the March recall? Do you remember the March recall? Do you remember, doctors? Or yes or no? You have forget Dr. Abba? Why? Do you remember that we were working so hard to find out about these, to differentiate when to go with sitagliptin and empagliflozin? Because we have to took some, no, not with you, exam week doctors. Sorry, not with you, exam week doctors. Yes. Okay, here. Yeah, this is this kind of question they can give. Okay, and the only theory you should know in here, increase ACR mean what? Creatinine, albumin creatinine ratios increase from this urine test, right? That means there is a excess albumin in urine. Excess albumin in urine. That is the main thing you need to remember. or we call it albuminuria, right? Yeah, very important. Okay, that is the most important point you have to take from increase ACR. Very important. Okay. Uh, there. Okay, this can be the question. There can be question they can ask like this. This example from the day 3 March records. Okay, a patient with BMI 40 and uncontrolled diabetes is found to have a albumin creatinine ratio of 500. The treatment. So here here in this question, okay, March question. This question type 2 diabetes, severe obesity, BMI 40, albuminuria, ACR is 500, very high, right? Indicate diabetic kidney disease, right? So in patient with type 2 diabetes and albuminuria, the drug that should be started if kidney function allows SGLT2 inhibitors like gliflozin. And I know this both of them, this semaglutide and this gliflozin, both have kidney protection. I'll show here. So both have kidney protection, but other than that, this SGLT2 inhibitors is empagliflozin, those drugs has extra protection, like extra indication for a CKD patient uh, with this albuminuria. Very important, doctor. Here, so SGLT2 inhibitors, how they work. These drugs reduce the blood sugar by causing the kidney to excrete the excessive glucose through urine. Benefit for kidney diseases, SGLT2 inhibitors have shown protective effect on kidney health and slowing the CKD progression and reducing the protein in the urine. Very important. Okay, what about this semaglutide GLP-1 receptor? They are safe for most CKD patients and have cardiovascular and renal protective benefits. They also have the benefit, but there's a specific indication for these SGLT2 inhibitors, like reducing the protein in the urine. Okay, this is the because in March exam we got this question with this question with this gliflozin and semaglutide. In that case, like this both we can use in the this higher BMI, the obesity patient with uncontrolled diabetes, right? To because both are indicated with these drugs. But the thing is, like we have to find out what is better, gliflozin or semaglutide. In that case, gliflozin take more place because of this albuminuria, right? It has the excessive protection for to reduce the protein in urine. Very important, right? Very important, right, doctor? Very important. Okay. So what about our? We didn't get a proper question here, but the thing is, like when we consider these things, okay, increase ACR. That means there is a proteinuria present. So what are the drugs that we can use? Tell me, doctors. Okay, what about perindrofil? Is it okay to use? Okay. Mm-hmm. AC inhibitors, right? Okay. What about indapamide? Here they are giving perindrofil to indapamide. Mm-hmm. Okay. What do you think? Yeah, in usually this case is yeah, AC inhibitors is better, but if they have like usually they are giving this scenario, this can be the same one. Okay, we assume this is as the same one. This is at the same one, usually increase ACR with related uncontrolled diabetes. If this is the question, go with this gliflozin, right? Gliflozin, very important, right, doctor? Because this is the not the complicated question, not the complicated question, but usually they are giving these like these two together, right? These two together, right, doctors? Anyway, we have to continue perindrofil. That is the thing. No need to change to indefinite if the patient is already tolerating perintropil. So there's no need of change in perintropil. So I think the question is the same: increase ACR with uncontrolled diabetes. So we can go with empagliflozin, right? I hope you understand what I'm saying, right? You can have a look from this question. Yes, right. So yeah, don't worry. Later we'll get the good question. Okay, now tell me, baby with cystic fibrosis being given treatment. Baby will have chronic lung problems. Baby will need pancreatic enzymes replacement. Baby will have intellectual disability. So, what do you think from these three? What do you think from these three? And I need the explanation as well. I need the explanation as well. Mm-hmm. Okay, why? Why doctor baby will have chronic lung problem? Okay, because cystic fibrosis patient can present with the chronic lung problems, right? There can be a pancreatic insufficiency as well, right? Like both are like overall correct, right? Right, doctors? What do you think? Anyway, the intellectual disability is out, right? Intellectual disability is out because it's not associated with the intellectual disability. Okay, we'll a little bit discuss about cystic fibrosis. Then we will discuss, okay, here. So, cystic fibrosis is an autosomal recessive multi-system disorder due to defective CFRT chloride channel, right? So, led to a thick dehydrated secretion affecting lungs, pancreas, gut, liver, and reproductive tract, right? Okay, so genetics. CFRD gene mutation caused impaired chloride and water transport across the epithelial cells, right? So pathophysiology, thick mucus, airway obstruction, chronic infection, bronchiectasis, pancreatic duct blockage. So exocrine pancreatic insufficiency, malabsorption, increase the sweat chloride due to impaired reabsorption and in sweat glands. So clinical feature respiratory chronic cough, recurrent chest infections, wheeze, bronchiectasis, GI failure to thrive, steatorrhea, abdominal distension, fat soluble vitamin deficiency, ENT, chronic sinusitis, nasal polyps, so reproductive male infertility. And remember, in I think 2024 or 5, not very clearly remember, they have given a scenario with this cystic fibrosis child, and they are asking what is the reason for male infertility. What is the reason for male infertility? So the reason is absence of vas difference. Very important. Okay, remember in the TG they have clearly mentioned this, all from TG. Okay, then other features: clubbing, salt loss, dehydration, so and related diabetics as well. So diagnosis: newborn screening. So what we are checking: immunoreactive trypsinogen, right? But the gold standard is what? Set chloride test. If it is more than or equal to 60 millimoles per liter on 2 occasions, we can confirm the diagnosis. So CFRD genetic testing for confirmation and family screening, right? Confirmation and family screen, but the gold standard is sweat chloride test. Supportive test, we can use fecal elastase, then chest x-ray, lung function test, like that. So the management, it's a multidisciplinary management, right? We all know, because it's associated with so many things, and we need to approach one by one. So airway clearance, medications like inhale bronchodilators, hypertonic salines, Donis alpha, right? Those are the things here. Mucolytics. Then antibiotics also given because of the recurrent infections, right? Patient need nutrition high diet, right? Pancreatic enzymes, fat soluble vitamins. So CFRT modulators for eligible mutants only, specific specialized care. The complications, you have to manage CF related diabetes, liver disease, osteoporosis, right? If the advanced disease present that affecting lung, you have to do the transplantation of lung as well, right? Okay, yeah, this is not related to that, but I have attached. So what about cystic fibrosis being given treatment? Okay, so from here, what we should consider. So here we can think like this because one and two both are correct, right? Is everyone agreed? Is everyone agreed? Yes, right. But we need to get the most important point, right? Okay, so what is happening in cystic fibrosis? There's a thick secretions, right? Thick secretions in the lung. Because of that, and this there can be a recurrent infections, right? Recurrent infections. Yeah. What about pancreatic enzyme replacement? But children with like all the children doesn't have pancreatic insufficiency, right? Like not all the cases. Some cases patient having pancreatic enzymes, right? Enzyme deficiency. Why? Because of the like if the patient is having only pancreatic deficiency and the malabsorption present, then only we are like poor growth and everything present, only we are thinking about giving pancreatic enzyme replacement, right? But here baby will have chronic lung problems, make more sense, right, when we compare these two, because only patient present with this insufficiency pancreatic, only we are doing this replacement enzyme replacement therapy. Otherwise, like when you consider baby will have chronic lung problem, it's like more like most commonest thing, right? Most commonest thing. Because of that we can go with that, right? But otherwise, like when we compare both of them, both answers are correct, but like most commonest one we can take is first one, having chronic lung problem because of these mucus, this thick mucus accumulation, and those everything like together can lead to the recurrent chest infections like chronic lung problems like bronchiectasis. Those can be happen, right, doctors? I hope everything is clear, right? I'll move to the next question. You can give it a read. Okay, this is not a very simple question, but this is not they are asking. Okay, okay, doctor. We will take a small break of 10 minutes. Then we will continue. Okay. But doctor, being on treatment, I think this will reduce the risk of lung problem. Yeah, it will reduce, but they're asking like it's only for pancreatic enzyme replacement, right? It's only make like a good prognosis for this malabsorption only, right? Doctor, it's not effective for the recurrent lung infections, right? They have given pancreatic enzyme replacement, right? Not overall. It's assess only one thing, right? But generally, the recurrent lung infections are very common, right? Yeah, yeah. No, no, doctor. We can't go with two. Like when we compare first and second, better to go with first answer, right, Doctor Above? Like in second answer, they only assess the pancreatic insufficiency only, right? But usually these patients present with the recurrent chronic lung infections, right? Recurrent lung infections, and like later they can lead to these chronic lung diseases as well, right? Yeah. Okay, so we'll take a small break. We will meet at 2:20. Hello, doctors. Hope you all back. We'll continue. Okay. Yeah. Next one. Is everyone here? Mm, yes. Yes, yes. So we'll continue. So delayed passage of meconium. So what is delayed passage of meconium? Tell me, doctors. What do you know about delayed passage of meconium? Mm-hmm. The main cause is, right? The main one is Hirschsprung disease, right? The most commonest one is Hirschsprung disease, right? Mm-hmm. Okay, this is not the only one, right? There's not the only one. Eh, The same thing. Okay, the same thing. This is not the only one, right? Okay. So what are the other things? Okay, before that, tell me like delayed passage of meconium. Usually that means failure to pass meconium within how many hours? Within how many hours? Okay, yes, within 24 hours, especially in term babies, right? Usually in what about like yeah, 24 hours. So if it is delayed mean how many hours? If it is if it is more than 24 hours, we call it delayed one. But usually, like if there's a like uh, very severe abnormality, we call it like after 48 hours, right? After 48 hours. So what are the causes? So causes can be what? There's some intestinal obstruction can be, right? And there can be functional disorders, right? Or motility disorders, right, doctors? Motility disorders. Then there can be disorders, right? Neuromuscular disorders. So what are the like intestinal obstruction disorders? Like this Hirschsprung disease, right? This Hirschsprung disease. Then there can be what? What is? There can be intestinal atresia, right? So malrotation, those things. But usually, like very common one is a Hirschsprung disease. So we assume that was Hirschsprung disease just because we only got delayed passage of meconium investigation only. Okay. So yeah, I think in later days we got the better question, but I'm not very sure about that. Yeah, we'll discuss about this Hirschsprung disease. So what is Hirschsprung disease? So, what is happening in this Hirschsprung disease? Tell me. So, what is happening in this Hirschsprung disease? Tell me, doctors, you should know something. It's a congenital absence of ganglion cells in distal bowel, right? Congenital absence of ganglion cells in distal bowel. So, because of that, it's failure to relaxation, right? Then because of that, there can be a functional obstruction, right? Yeah, this is the Hirschsprung disease. So, pathophysiology, failure of neural crest cell migration affect the rectosigmoid most commonly, right? Then proximal bowel become dilated and distal segment become narrow, right? So, classic presentation. Usually, failure to pass meconium more than 48 hours. Like, that's what I told. Like, if it is more than 48 hours, there's a suspicious is very high about this Hirschsprung disease, right? So, then abdominal distension, bilious vomiting, tight anus, empty rectum, right? Explosive stool after perectic exam, right? Then, okay, so this is also like Hirschsprung disease symptoms, the most common one. This is from Australian guideline, okay? So this is from RCH, okay? You can have a look. I have attached the reference. They have given like this kind of PDF for Hirschsprung disease. So failure to pass meconium, a newborn's first stool in the first 24 to 48 hours of life, right? Swollen tummy, vomiting, temperature. Then children may have these signs, severe constipation, delayed growth, poor appetite, sepsis, like diarrhea as well. So investigations. Initially, what we should do, abdominal X-ray, right? So what we can see, dilated bowel loops, multiple air fluid levels suggest that distal obstruction, right? So, what are the screening test, doctors? So, everything from the guideline. Okay, okay. We'll do some questions. Then we will come back to this. Then you will betterly understand. Okay. So here. A 5-day-old boy present to the emergency department with a history of passing scanty meconium for the first 2 days of his life and no bowel movement since. His parent report increase in abdominal distension over the last 48 hours associated with poor oral intake and several bile-stained vomit. He was born at a term by spontaneous vaginal delivery following uncomplicated pregnancy. He does not take any regular medications and no significant medical history. On examination, he appears unwell with pulse rate 160, respiratory rate 60. Temperature 37.8, SpO2 98. Abdomen is soft but distended. Rectal examination produces a gush of gas and liquid stool. A plain abdominal X-ray shows the gaseous distension with multiple air fluid level at various sections of the small and large bowel. Right. So they're asking which one of the following is most likely diagnosis. Actually, it's a Hirschsprung disease. Why? The patient present with classic symptoms of Hirschsprung disease, including failure to pass meconium, abdominal distension, bilious vomiting. Hirschsprung disease is characteristic by uh, aganglionic bowel segment, most commonly in the rectosigmoid region. The anoganglionic segment failed to relax, preventing the passage of meconium and leading to a typical symptoms. On physical examination, Hirschsprung disease is classically associated with the explosive release of stool from the anus once the finger is removed after digital rectal examination. Uh, so, as seen in this case, the plain abdominal X-ray showing a abdominal distension with air fluid level further support the diagnosis, right? Okay, here. So, next question. Because we'll go one by one, then you will understand. 7-day-old boy present to the emergency department with failure to pass meconium since birth. Progressive abdominal distension, bile stain, vomiting. He was born at the term by a normal vaginal delivery with no complications. Um, his newborn examination was unremarkable. He has no other medical history and take no regular medications. On examination, he appears unwell with pulse rate 160, respiratory rate is 60, temperature 37.8, abdomen is markedly distended and tympanic to percussion. A plain abdominal radiograph showed the dilated bowel lobes with multiple air fluid level. What is the most appropriate definitive management? So, what do you think? Okay, without seeing the options, can you tell the definitive management? Just give it a try. Just give it a try, doctors. Give it a try. Give it a try. Okay, I'll tell the answers. Okay, saline enema decompression one, then temporary colostomy, pull through operation, regular osmotic laxative. What do you think? Just 1 minute, doctors. Answer in the. What do you think, doctors? Should I read the questions? Sorry. Yes. Okay. So here, this is the so you need to remember one by one what is the definitive management, right? So it's a pull through operation. I hope everyone know about this. The patient present with a Hirschsprung disease. So pull through operation is a definitive treatment for Hirschsprung disease. Sorry, several surgical technique exist. Swenson, Duhamel, like you don't need to remember, just remember pull through operation, but all involve removing the aganglionic segment and connecting the normal innervated bowel to the anal canal, right? This procedure have excellent long-term outcomes with most patients achieving normal bowel function. Very important pull-through operation. What about saline enema decompression? Here it may provide the temporary relief of obstruction but does not address the underlying pathology. Because I know most of doctors are remembering this saline enema as the definitive treatment. It's not. Definitive treatment is always surgery, right? You have to remove this aganglionic area from the colon, right? Yeah. So, what about contrast enema may be useful to diagnostically to demonstrate the transition zone between normal and aganglionic bubble, but it's not therapeutic, right? The definitive diagnosis require rectal suction biopsy showing absence of ganglion cells, right? Very important points. Okay, here. Next question. Two-day-old male infant present to the hospital with his parent with failure to pass meconium, abnormal distension, bile stain, vomiting. He was born at a term via normal vaginal delivery, which was uncomplicated. He has no significant medical history. On the examination, he appears well with a distended abdomen. Vital signs are within normal limit. Plain X-ray shows the gaseous distension with several air fluid. They are asking which one of the following investigation most likely to provide the definitive diagnosis. So, what is the definitive diagnosis? I just told you. So, what is the definitive diagnosis? What is the definitive diagnosis? I just told you. Rectal biopsy, right? Very important, right? These things are very important, doctor. That's why I have added during the exam week as well, because you need to follow these things, because this is a kind of new topic, not a new topic, but we haven't touched this topic during our past sessions, right? Yeah, so initial abdominal x-ray, then screening test. We can use contrast enema to see the transitional zone, right? Narrow distal and dilated proximal bowel, then rectal manometry you can use, right? So the definitive one, rectal suction biopsy. I made this note from the emergency questions, okay? There's a gold standard and absence of ganglion cells you can see from this biopsy. In the management, initially you have to stabilize the patient because there is a intestinal obstruction is ongoing, right? You have to stabilize by need by mouth, nasogastric tube decompression, intravenous fluid, rectal saline washout if needed for temporary relief, right? The definitive management is pull through surgery, removal of aganglionic segment and anastomosis, then normal bowel to with the anal, right? Yes. So not appropriate osmotic laxative or ineffective. Contrast enema is diagnostics only. Colostomy is rarely required and used only in selected cases. This is all from the emergency, okay? So I hope everything is clear. So you need to know like definite what is the definitive ones, right? Because they can ask and you can think about like other options. Because of that only I'm telling. Please like go through this note because we haven't covered this topic even not even in our theory class. So because of that, very important. Keep these points in your mind, right? Okay, hope is everything clear? Do you have any problem? So you have a task. You have to make a small short note for this Hirschsprung disease using my note. Okay? Yeah, this one. Next one. Distal radius fracture management. No X-ray has given. So what are the distal radial fractures? Tell me, doctors, what are the distal radial fractures? Give me example. Distal radial fractures. Tell me. So what are the distal radial fractures? Okay, only calls. We have calls, Smith, right? Then we have Barton fracture. Different types, right? Because we don't know which type of fracture they have given. Just distal. Most probably it is Coles fracture because AMC's favorite topic is what? The Coles fracture from distal radial fractures, right? Here, doctor. Here also they have given different types of distal radial fractures. Yes, yes, green stick fracture like pediatric population, right? Yeah. Okay, these are the distal radius or ulnar metaphyseal fracture. So here, You can give it a rate like different types of the complete displaced fracture. They have not like mentioned from the like different types, not cause like that. They have just given like if it is displaced or not like that. Okay. So we'll go through this one as well. Then we will discuss about this myth and cause fractures as well. Okay, here. So the buckle injury. So what is buckle injury? So what is buckle injury, doctor? Tell me. Tell me, doctors. Okay, undisplaced. Okay. It's like a compression fracture, right, doctor? It's like a compression fracture. Yeah, it's undisplaced. It's a compression fracture, right? Usually, we can see this in pediatric population, right, doctors? Yeah, pediatric population. So, in the buckle injury, remember it as a compression fracture. It's an incomplete compression fracture. Okay, remember. So in those cases, what we should use below elbow, finger glass, plaster backslap or removable wrist splint for removable wrist splint for 3 weeks. Okay, and no follow up needed. So in if there's an incomplete or undisplaced or minimal displaced fracture, you have to refer for the orthopedics and below elbow cast for 6 weeks. Then fracture clinic within you have to do the follow up in 7 days with sorry, not chest, hand X-ray. So complete displaced fracture. So here we you have to do the close reduction with immobilization below elbow cast for 6 weeks, right? So like usually if there is a, okay, this is the general idea for fracture, most of the fracture, because like we have discussed so many fractures, types of fractures in March recalls, right, doctor? So what is the final conclusion you can got from this fracture management? Just a simple conclusion. Okay, if it is displaced and undisplaced, if it is displaced, yeah, if it is displaced, we need to do the reduction, right? It can be open or right close reduction. If it is like a non-displaced fracture, then we need to immobilize with those plasters, right? Those different types of back slab, below elbow cast, those things. Okay, like general idea. So I think this is distal radial, like the main thing in our mind is cause fracture. So we'll discuss about cause fracture and Smith fracture. But remember these type of things also can be present. We don't know either it's a elderly patient or young patient or pediatric patient. So we need more details actually. That's fine. We'll little bit discuss about this cause fracture and this Smith fracture. So, what is the cause fracture? It's a distal radial fracture with dorsal displacement. So, what is in Smith fracture? Smith fracture, it has a distal radial fracture with palmar displacement, right? Palmar displacement. The mechanism fall on outstretched hand, right? Fall on outstretched hand. This is the mechanism of cause fracture. So, Smith fracture fall on flexed wrist here. Yeah, usually impact on flexed wrist. A Smith fracture, the Cole's fracture, like mechanism is like outstretched hand, right? Outstretched hand. So then deformity. So we have two types of deformity, especially for Cole's one, we have dinner fork deformity. For the Smith fracture, we have garden spade deformity, right? So here, garden spade deformity, you can see here, right? You can see here. Can you see? Can you see here? Then for the cause fracture, we have the dinner fork deformity. Dinner fork here. It's like a dinner fork. Then, yeah. Then more common is the Coles one, less common is Smith fracture. So age group usually Coles fracture. We can see in elderly patient who are having history of osteoporosis like that. But Smith fracture usually in younger high energy trauma, right? Because the hand is flexed on wrist, right? It's a fold on flexed wrist. Then clinical appearance, wrist bend backward here. In wrist bend forward here, right, doctors? Yeah. Wrist, okay, wrist. Then complications no need. So let's see. Okay, we'll do some questions. Then we will discuss about the management. 52-year-old woman present to the acute pain in her wrist after falling on her right hand. On examination, there is a tenderness over the wrist, but do not appear deformity or swelling. X-ray is performed. The X-ray is performed. The X-ray is performed. X-ray is performed. So they are asking after adequate pain relief, which one of the following is most appropriate management? Tell me, doctors, what is the answer? Tell me. Okay, okay, here. So let's see. The patient has fallen on her outstretched hand, causing cause fracture, which is shown on the X-ray, right? It is appears minimal displace, hence it does not require any reduction here. Can you see the fracture here? You can see it right here. Okay. It's not it's a minimally displaced, right? Minimally displaced fracture. So because of that, just mold below elbow cast for 5 to 6 weeks is enough, right? This conservative approach is less invasive to avoid the risk of associated with surgery. If the fracture were displaced or caused any neurovascular changes, then surgical interventions would be necessary. So remember about the treatment, right? If undisplaced, so usually this elbow cast is enough for 6 weeks. If the neurovascular compromise and this is the fracture is displaced, so um we need the surgical reference, right? Often when a fracture is very displayed or there is a plan for surgical fixation on the in the not too distant future, then backslab is used, right? Okay. In this case, where the fracture is essentially undisplaced, then immediate applications of modeled full cast is appropriate. Sometimes the patient would be monitored hospital overnight for swelling to ensure the cast does not need to be split, right? So applications of backslap would not be unreasonable, but would be necessary to definitive management as later date. That there be the surgery which his fracture does not need, or applications of molded cast, right? Rest applications of molded cast has been mainstay approach to the management none or minimal displaced distal fracture. The options remaining controversial in the term of gold standard care. Okay, now I'm going to ask this. This cast is like, uh, tell me the typical appearance of this cast. Typical appearance of this cast. Typical appearance. Tell me, doctors, what type of cast is this? Okay, we call it, it's like a handshaking cast, right? Okay, I'll show. Here, very important. This is the calls cast, okay? So it's like a handshaking cast. You can remember it's like a handshaking cast below elbow, and you should know. So how this present? Palmar flexion and ulnar deviation. Palmar flexion and ulnar deviation. This type of cast is present in Skull's fracture, right? I hope you remember because sometimes they are asking about this palmar flexion and ulnar deviation as well. Very important, right? Very important. Right, doctors? I hope everything is clear. Don't worry, we'll get a better question later because this is day one, right? So, next on oppositional defiant disorder and antisocial. So, what is ODD? What is the diagnostic criteria for ODD? Okay, what are the clinical features of ODD? First, tell me the clinical features of ODD. Doctors, ODD was another hot topic in March exam. Tell me about ODD. Yes. Yeah, so ODD, oppositional defiant disorder, in a childhood behavior disorder is present in with ODD, won't do what people ask, right? They are not doing what people ask. Think that they are doing being asked to do is an unreasonable thing, right? Get angry and aggressive about being asked to do such things, right? They don't want to listen to others, like they don't want to listen others orders, right? They are thinking it's not appropriate to do what others asking, right? Yes. And they are always getting irritable and aggressive once someone asks to do something, right? Okay. So here, children with ODD have at least four symptoms that negatively affect their activities for at least 6 months. So, what are these key symptoms? Often lose their temper, are often touchy or easily annoyed, are often angry and resentful, often argue with adults, actively refuse to do what adults ask and disobey rules, often deliberately annoy people, often blame others for mistakes or change in behavior, or often nasty and unkind, right? Very important. My doctors, I hope you remember about ODD behavior. Now tell me how we should treat initial management. We always start with the non-pharmacological therapy, right? Non-pharmacological therapy. So we have to start with the behavioral support for these patients, right? CBT. Okay. So what about conduct disorder? What about conduct disorder? I have attached to differentiate ODD and conduct disorder. So what is a conduct disorder? Because you need to differentiate ODD from conduct disorder. Tell me. Okay. A mini criminal, yes. Yeah. So before discussing conduct disorder, you should know like this conduct disorder, okay, we'll discuss this one. Then you will identify, okay, about this conduct disorder. So this is DSM-5 criteria, a repetitive and persistent pattern of behavior in which the basic rights of others or major age-appropriate social norms or rules are very violated, as manifested by the presence of an least three of following criteria in the past 12 months, with at least one criterion present in the past 6 months. Okay, so what are those? We have three criteria: aggression to people and animal, destruction of property, um, deceitfulness of theft, then serious violation of rules. So each like here what they are mentioning presence of at least three of following criteria and in the past 12 months and at least one of criteria present in 6 months. Very important, right? Very important. So and so, what are the features in aggression? Often bullies, threaten or intimidates others, often initiate physical fight, has use of weapon that can cause serious physical harms to others, then like throwing bricks, broken bottles, knife, gun, and has been physically cruel to people, has been physically cruel to animal, right? Animal cruelty, so has stolen, confronting a victim, stolen and confronting it as a victim, And mugging, purse snatching, then armed robbery, like that. So has forced someone into sexual activities. So destruction of property has deliberately engaged in fire setting, right? Fire setting and intention of causing serious damage has deliberately destroyed the other's property. Then deceitfulness of the theft has broken into someone else's house, buildings, or car, often lie to obtain good or favors to avoid the obligations, has stolen items of non-trivial value without confronting victim. So serious violation often stay out to the night despite parental prohibition. Beginning before age 13, very important. Beginning before age 13 has run away from home overnight at least twice while living in the parental surrogate home, or once without returning for lengthy period. Often run from school beginning before 13 years, right? Okay, so the disturbance in behavior cause clinically significant impairment in social, academic, or occupational functioning. If the individual is age 18 years or older, criteria are not meant for the antisocial personality. So usually, if this child the conduct disorder after 18 years, we call it antisocial, right? Antisocial. Okay, there's a question. 14-year-old boy presented to the GP clinic with his parent for assessment of escalating behavioral concern. Over the past year, he has become increasingly defiant and home and school, frequently arguing with teachers and refusing to follow rules. He has been suspended twice for fighting after become angry when challenged. His parents notes that he has been stealing small items from the shop and staying out past curfew despite consequences. He lives with his parent who has a history of depression, substance use, and biological father is incarcerated. Has no significant medical history and no regular medications. On examination, appears well, vital signs normal. He is appropriately dressed but avoid eye contact. When discussing his behavior, he became defensive, stating everyone is always against me and that's other student I started it. He shows a little concern when told how his action affect others. His parents appear overwhelmed and tearful during the consultation. So what do you think? What is this, doctors? Type your answer. This type of question you can see. This type of question you can see during the exam. So what is the answer? Tell me, doctors. What do you think? Okay, what about other doctors? We are having 12 doctors currently. Mhm. Okay. Yes. This case presenting a diagnostic challenge between conduct and ODD, right? That's why this is a one of best question. This can be so confusing, both of which can present with defiant behavior and poor emotional regulation. However, several features point more strongly towards the conduct disorder. So, what are those? Characteristic by pattern of behavior that violate the basic rights of other homage age appropriate social normal, while this patient show the features that overlap with the oppositional disorder like arguing defiance, the presence of premeditated stealing and physical aggression along with the lack of concern for others, the more consistent with conduct disorder, right? I hope you understand why it is a conduct disorder, why it's not ODD. Is everything clear, right, doctors? Just 1 minute. Is everything clear? Okay, very good. So you need to differentiate these things, okay? Here, here oppositional defiant disorder, antisocial, because I assume this because ODD and antisocial, the younger version is conduct disorder, like the recaller bonds to give actually ODD and the conduct disorder differentiate. This can be the right related question they actually ask in the exam, this kind of question, okay? So always keep these points in your mind. So domestic violence case, repeat question, answer, investigate one separately. So here, this is the only recall we got. Now tell me how we should manage domestic violence case. Tell me, doctors, how we should manage. Okay, I'm asking questions. Okay, if there's a patient coming with bruises and everything, after the consultation, the patient has revealed to doctor that there was a domestic violation in his home, in her home. Okay, and then okay, so you know there's a domestic violence. So can we report to police or not? Can we report to police or not? I'm just asking question. Can we report to police or not? Okay, what about other doctors? Can we report? Mm-hmm. No, right? Yes. Okay, then next option. Can we advise patient to that you have options to call the police? Can we advise patients? Yes, we can advise patient to report this scenario by herself. Only okay, in there another one. Okay, then you explain the patient like what they can do, and then she asks. Okay, then she give consent you to report to police. She's agreeing with reporting police. Then she asks you to report with her consent. Can we? Yeah, we can, right? Because it's a patient's it's under patient's right, it's under patient's consent, right? Patient is the one who asked to report it, right? Right, doctors? So with patient's consent we can report, but without, okay, the next scenario, so you have given options like patient that she can report the police, then she doesn't want to report to the police, then what else you can do? Patient is not agreeing with reporting police because she doesn't want to report it to police, then what you can do as for her, as for her say? No, no, doctor. We can't report. We can't report because he's a 18 plus, right? Adult patient. We can't report. Even though there is a rape case, we can't report directly to the police. Everything under their concern. If only patient agreed, only we can report. This is a very, very old question, right? So the next thing what we can do is, if she's not agreeing to report to the police, next thing we can do is arrange some safety plan, right? Safety plan. These are very important things, like very usual points, right? This is a February call. Woman came to hospital injured but said her partner beats her, but also said don't tell police cause she won't leave him. She won't leave. This is the February call, okay? She won't leave him. So in that case, what we should do, develop a safety plan with the patient, like escape plan, provide information and support service and advice police assistance is available while respecting the patient's decisions if they do not want to police involvement. So how you should manage, assess the immediate safety. Once the patients feel safe of going home, check if there is any immediate danger, then you can arrange a safe plan or escape plan, right? So here, plan of safe escape. Identify a safe place they can go in an emergency, such as a friend's house, family member, or shelter. Plan how to leave quickly if violence starts, like that. This is the only thing we can do because by ourselves it's not possible to report to the police. Very important, right? Because he's an adult. Because these people are adults. It's their right. Like they can. If they want only, we can report, right? Yeah. I hope everything is clear. I don't know why answer investigate women separately. This is not a proper answer. So if the domestic violence scenes, you see the question, follow these things. That's only. Everything is here. You don't need to think about any other thing. Just follow this. Okay. This is a question. 32-year-old woman from Queensland pretend to present to GP clinic requesting medical certificate for work. During the consultation, she appeared distracted and anxious. When asked about her well-being, she hesitantly disclosed that her partner of 8 years has been rough with her during during argument. On further questioning, she revealed episodes of choking during the intercourse and appears uncomfortable discussing this. She minimized two previous presentations of different emergency departments with accidental injuries. Sorry. Sorry for that. Then she has no significant medical history and has taken no regular medications. On examination, she appears well groomed, anxious, pulse is 100. Like everything, blood pressure a little bit high, 40 to 100 and 40 to 90. SP to 98. There are fading bruises around her neck and wrist, which she attributes to bedroom activities. When asked directly about safety, she says, I know what you are thinking, but it's complicated. I see domestic violent cases every day because she's a lawyer, right? In my work, this is not like that. Beside, it would ruin both our careers. Which one of the following most appropriate next step? Very important, doctors. I know this question has done by me multiple times in our recall sessions, but you need to answer, right? So, answers develop a safety plan with the patient. Very important, right? Develop a safety plan with the patient. So, why not mandatory reporting to the police? Listen carefully. Without the patient's consent, even with a high risk features of strangulation, could escalate the danger and destroy therapeutic alliance. Give the partner's position as the police officer. This could be at her increased risk anyway. However, the risk of strangulation should be clearly documented and discussed with the patient as per safety plan. Right? We have no right to report to the police. Very important, doctors. Okay, very important. Next question. Patient comes with sudden severe anal pain starting 24 hours. Picture of mass coming out from anus. Management. So what it could be? What it could be, doctors? What it could be? Tell me. Tell me what it could be. Why abscess? Okay, here. Okay. What are the types of anal bulge, anal masses coming out from anus? This is not like just outside the anus. This is picture that mass coming out from anus. So what are the things that coming out from anus? Hemorrhoids, right? Hemorrhoids. Hemorrhoids also we have two different things. We have external hemorrhoids and internal hemorrhoids. Now tell me different features of external hemorrhoids and internal. So first internal is painful or painless. Internal one. Internal one usually painless, right? Usually painless. Then what are the types of internal hemorrhoids? We have four grades, right? So tell me first grade how it present here. Grade 1 internal hemorrhoids. How it present? Do not prolapse, right? Do not prolapse. Grade 2, hemorrhoid is prolapsing during the defecation and reduce spontaneously. So grade 3, hemorrhoid prolapse and require manual reduction. You need to put it back inside the anus, right? Manual reduction needs. So grade 4, hemorrhoids prolapse and irreducible. That mean even though with manual reduction, we can't put it back, right? So this is great for hemorrhoids, right? Very important, right? Very important, doctors. And here the symptoms of internal hemorrhoids, bleeding, we can see bleeding, right? Mucus discharge and it's a itchy, right? Pruritus, right? There may be or not prolapse down the anal canal. Like according to the stage only, we decide the treatment. Now tell me what are the management options we have. If it is a type 1, if it is a type 1, grade 1 internal hemorrhoid, what we can do? Grade 1. Tell me, doctors, grade 1 internal hemorrhoid, what is the management? Conservative management, right? Lifestyle modification, yet conservative management. Diet, right? Dietary modification, like those things. If it is grade 2 hemorrhoids, what we can do? Grade 2. Yes. If it is grade 2, what we can do? We can do like rubber band ligation or injections, right? In sclerotherapy, we can use these injections and these ligations. Okay, if it is third degree and fourth degree, we have to think about hemorrhoidectomy, right? Hemorrhoidectomy. But usually, sometimes third degree cases also, we can use these ligation or injections. But like if it is not working anyway, the definitive one is the surgery, right? For fourth one, the surgery is the definitive one because we can't reduce it back, right? The surgery is the definitive one. This is how it present. So if you want, you can give it a read in here. Then let's discuss about external hemorrhoids. So external hemorrhoid features. So external hemorrhoid features. Is it painful or painless? Bleeding present. What about is it painful or painless? It's a painful one, right? It's a painful one. And so external hemorrhoids also, we have different types, right? We have external hemorrhoids, and there's a one specific one we call it thrombosed external hemorrhoid. So what is this thrombosed external hemorrhoid? Mm-hmm. Yeah, we have thrombosed external hemorrhoid. This is a type of external hemorrhoid. So what is here? So external hemorrhoid originates below the dentate line and covered with a squamous epithelium, which is why it's a painful, right? Which is why it's painful. An external hemorrhoid may become thrombosed sometimes as a strain during defecation. A thrombosed external hemorrhoid, or we call it perianal hematoma. Very important, but it's not an actual hematoma. But we call it perianal hematoma. Why? It look like a hematoma, right? Here it's look like a hematoma, but it's not an actual hematoma. Very important. Not actual hematoma, right? Yeah. Appears as extremely painful, tense, blue swelling at the anal margin, although sometimes called perianal hematoma. The clot is contained with the endothelium, endothelium line blood vessels. Is not a true hematoma, right? Very important. It's not a true hematoma. So here, then what is the management? So tell me about the management. Mhm. So, if these patients are presented within 72 hours of onset symptoms like severe pain, those things, we can use the excision. We can use excision under local anesthesia, right? Excision under local anesthesia. And to avoid recurrence, it's important to excise the entire hematoma, leaving an open wound, right? A simple incision should generally be avoided because it has a higher rate of recurrence and worsen symptoms, right? And doctors, I hope everything is clear. But in some cases, if this is not available to give the immediate relief, we have to do the incision and drainage as well. Not drainage, actually incision usually. incision we have to do to give the immediate relief, but it's not appropriate because the recurrent rate is high, so we have to fully excise it, right? Okay, then pain caused by thrombosectional hemorrhoid begin to settle in 1 to 2 weeks without treatment as but why we are waiting to settle by its own, right? Because it's very painful, better to do something, right? Yes. Okay, I hope you understand here. And here these are the types of hemorrhoids. Strangulated hemorrhoids, the perianal hemorrhoids, right? Yeah, those things. And here pain alone, pain lump, those things you can see. Okay, here the patient comes with sudden severe anal pain starting 24 hours ago. Picture of mass coming out from anus. This can be external hemorrhoid or this thrombosed external hematoma. So, like, better to go with this excision, right? Because it's still 24 hours, right, doctors? Still 24 hours, right? What do you think? Actually, we need to see the proper scenario, but it seems like some external hemorrhoids, right? Seems like external hemorrhoid because of the pain and the mass coming out from anus, right? Okay, so here look for excision under local anesthesia. If this option is not available, choose incision and drainage as it can provide rapid pain and relief. Okay, usually incision we can use here. But it's only other options are not available only. Okay, very important because incision, this IND, it has what? It has the recurrence rate, higher recurrence rate, right? So better always go with the surgery, like full excision. Okay, and 1 minute. There was a one question in 1 minute in February file. Just give me because I just remember it. It's a better question. Okay, don't worry. It's a good picture. Okay. Okay, this one. Because you need to familiar with these pictures. Okay. Do you remember we have done this question in February? 35-year-old man present to the emergency department with 24-hour history of painful swelling around his anus. I think this can be the picture, okay? This can be the exact question because we already know they are giving direct question from email, especially the pictures, okay? So this followed an episodes of constipation and strain in and stool. He has no significant medical history and does not take any regular medication. So on examination, he appears uncomfortable. His vitals signs within normal limit. Perianal examination seen below here. Which one of the following is most appropriate management here? What do you think? Tell me, doctors, what we should do. Okay, first of all, tell me what type of hemorrhoids is this? What type of hemorrhoid is this? You remember the question, right? Yeah, you remember the question, right, Dr. Abba? Yes, yes. Okay, like if we see this question, it's almost seems like what? Almost seems like it a thrombosed one, right? Thrombosed one, but this thrombosed external one, but this is a thrombosed internal hemorrhoid. Thrombosed internal hemorrhoid. Done it 100 times. Yeah, yeah. That's why even I also remember here. So the answer is acute hemorrhoidectomy. The patient has a prolapsed and thrombosed internal hemorrhoids. Prolapsed and thrombosed internal hemorrhoid, right? This can be the exact thing. The hemorrhoids can be seen protruding down the anal canal. There's ulceration over the prolapsed hemorrhoid. The thrombosis is a serious complications of internal hemorrhoids. Patient with thrombosed or strangulated hemorrhoids present with severely painful and irreducible incarcerated hemorrhoids, which may be necrotic. Acute thrombose of internal hemorrhoid can be extremely painful and distressing even in the patient has only 24 hours of symptoms. This effective way of giving this patient is a rapid relief from the symptoms to perform acute hemorrhoidectomy, especially due to the overlying skin ulceration. Unless the surrounding tissue is necrotic, mucous, or anoderm should be preserved, prevent post-operative anal stricture. Delaying the active intervention with pain relief and elective hemorrhoidectomy would be just and to the patient's misery. However, the patient presented with more than 72 hours of symptoms, as commonly occur, the edema and pain has less are likely already peaked, in which case conservative management is the best and acute hemorrhoidectomy at this stage will cause more pain, right? If it is less than 72 hours, better to go with hemorrhoidectomy, but if it's more than 72 hours, we can use the conservative management as because the hemorrhoidectomy can be more painful. So what about incision? If this was a perianal hematoma, their incision and evacuation of the hematoma would be appropriate for the external hemorrhoid, right? External perianal hematoma. It's appropriate to relieve the symptoms. That's only okay. I'll attack this question again because it's a very important question. I feel like this is the question they have given during the exam week. Right, Dr. Abba? The system is very, very like similar with the very similar.